I'm Mark McKenney. I'm the Chief of Trauma at the University of Miami Hospital and a trauma surgeon at the Ryder Trauma Center, part of Jackson Memorial Hospital. The last 10 years have been very exciting. We've seen a significant drop in the mortality rate, both in the military and in the United States setting. The big changes are we're now able to access vessels that were very difficult to access before and took long periods of time while the patients were bleeding. And we have new ways to resuscitate patients that are in shock from bleeding. So in the past, we used to resuscitate patients with a saline solution, some salt that was sterilely put into water and mixed up at an appropriate level. And it works pretty well, but we found out that there are even better ways to do it. This was mainly driven by the military. The salt solution is quite heavy, and when the military is out on patrols, they're trying to limit the amount of weight. So they came up with a new solution, which was about 1/5 the weight, allowed them to carry 5 times as much, and has a sugar-based solution called Hexten is the trade name. And the military started to use it and actually contracted with us to do one of their major studies, and it worked out phenomenally. The resuscitation was much better. We got them out of shock much faster. They died at a lesser rate. So we've incorporated it routinely now into the patients that are in shock, and the military has been doing this since their campaign began. So in earlier conflicts, if you were wounded in an extremity, something that was accessible from the outside, it was very difficult to control it. You could put direct pressure, but it was hard to get any deep pressure into an artery or vein that was bleeding. So with the military and with industry, blood sealants have been developed. And these are powders. They come on a gauze platform that you can put directly on the wound, and it's amazing how quickly it stops the bleeding. It's so effective, actually, we've started to use it internally. So we routinely use it now externally when they're bleeding in an extremity, and perhaps they're injured in the liver, the spleen, or the kidney, and you operate, and you go on the inside, and you can actually place this right onto the organ, and it stops bleeding. The original concoction actually led to a real thermal reaction where it would burn the skin, and then they figured out how to improve that, so it's mildly warms up, but nothing dramatic. And the sealant properties are about 10 times stronger than just pressure alone. So there's a couple vessels that are nearly impossible to get to surgically. One of the vessels is called the internal iliac, and the other one's called the vertebral artery. They're highly protected. They're central in the body. Usually you don't even know this is the vessel that's bleeding, so routine incisions don't allow it to be accessible. It can take 1 or 2 hours of dissection to get to the vessel, which is a long time when a patient's bleeding. So we started to realize, well, there's got to be a better way. And then we started to partner with the radiologist and realized that they could do an angiogram, a dye study in a vessel, and see the vessel. And the next step seemed kind of obvious. Maybe they could actually put a balloon into the vessel and stop the bleeding. Or what it's evolved into is they have little metal coils, and they inject the coils into the vessel and block it up. This has been extraordinarily effective. And the routine treatment now for severe bleeding from the internal iliac or vertebral artery is to call your radiologist, have them come racing in, and they do an angiogram, and then it's called an embolization, where they embolize the vessel and stop the bleeding, which is much more effective than our previous methods. Yeah, that's been another huge change, which has led to much better outcomes. Our mortality rates are coming down in traumatized patients and in critically injured patients or critically ill patients. There's really 2 main types of shock we deal with. One is just straight bleeding, which is hemorrhagic shock. And the other one is after you've bled a lot, you're at a hugely increased risk. You can finally stop the bleeding. You resuscitate the patient out of shock, but they've lost so much blood, they're at much increased risk of having an infection. And a severe infection is called sepsis. Then they go back into shock, and frequently it's fatal the second time, but we've gotten better at resuscitating the patients the second time with shock. There's 2 ways we do it. There's really 3 ways. We give them antibiotics to combat the infection, which we've always done. We have something called an activated protein C, which is used in sepsis and allows us to treat the sepsis better. It reduces the mortality rate by 15%, and we've gotten better at resuscitation too. We've started to use low doses of pressor agents which help raise the blood while we continue to give them fluids. In the past, we've either used just fluids or just pressors. Now a combination of the 2 with the appropriate antibiotics and this activated protein, which combats sepsis, has had a marked reduction in sepsis in the last 10 years. One other big change, which I've done with my wife actually, I'm married to a radiologist. In the past, to look for internal bleeding, we would put a needle into the abdominal cavity, and if you were in a rush, which was frequently the case because they were in shock and unstable and you were trying to find out where the bleeding was, so you'd blindly put a needle in past a catheter and instill some fluid and pull the fluid back and try to see how bloody it was. And it worked, although the blind needle stick had a number of complications and you had to be trained in the technique. So we started to look at, well, there's got to be a better way. And we realized that ultrasound is a great way. The machines got very portable. 20 years ago, they were the size of your refrigerator. Now they're the size of your laptop. You can walk around with them. You don't even need wheels if you have the lightest one. You can actually just turn it on, put the probe on the abdominal cavity, the chest cavity, and over the heart, and it is phenomenal for looking for blood. The whole process takes about 5 or 6 minutes, and that includes warming up the computer or the ultrasound machine. It's as accurate as our previous methods. It's much faster. It has no invasive component. The training process on it is actually less than the invasive procedure. And it allows us not only to look at the blood, but to quantify it, and you can repeat it every minute or two to see if the blood is continuing to increase. There's even a scoring system, which carries my wife's name, actually, called the McKinney score, which allows you to actually quantify the amount of bleeding, and you can see if it changes over time, which would let you know that the patient's continuing to bleed and then probably needs an operation in order to stop the bleeding. So in 1990, it was not done in the United States. And this year, it'll be done about 5,000 times at our trauma center. Across the country, it's probably in the several million times.